Good day, esteemed colleagues and future dermatology luminaries. Today, we embark on a captivating journey into the realm of Staphylococcal Pyoderma, a common yet intricate bacterial skin infection that occupies a pivotal space in dermatological practice. Imagine walking through a bustling marketplace where every corner, every stall, and every passerby holds potential stories of skin health and disease. In this lecture, we will unravel the narrative of Staphylococcal Pyoderma, exploring its origins, manifestations, diagnostic pathways, and the therapeutic strategies that empower us to restore and maintain the integrity of our patients' skin. Setting the scene, the epidemiological landscape. Picture a vibrant community, teeming with children playing under the warm sun, individuals engaging in daily activities, and environments ranging from pristine to modest in hygiene standards. Staphylococcal Pyoderma thrives in such settings, weaving itself into the fabric of everyday life with a higher prevalence among specific populations. Who are the main characters? Children and adolescents, the energetic youth, with their active lifestyles, often serve as the primary hosts. Their developing immune systems and frequent skin-to-skin interactions create an ideal environment for staphylococcal colonization. Adults with compromised immune systems, individuals battling conditions like diabetes, HIV/AIDS, or those undergoing immunosuppressive therapies become vulnerable protagonists in this narrative. Geographical influences. The story is more intense in tropical climates and crowded urban areas where hygiene practices may falter, providing the perfect backdrop for infection to take hold. Risk factors. The plot twists. Compromised skin barriers, whether through eczema, burns, surgical wounds, or dermatitis. Any breach in the skin's protective shield invites the staphylococcal invaders. Environmental and social factors, overcrowded living conditions, poor sanitation, and recent antibiotic use add layers of complexity, often leading to the emergence of resistant strains like MRSA. The antagonists, causative organisms and their arsenal. At the heart of our story lies the formidable Staphylococcus aureus, the primary antagonist in Staphylococcal Pyoderma. This bacterium is not a one-dimensional villain. It comes in various forms, each with its own set of challenges. Methicillin-susceptible Staphylococcus aureus, MSSA, the classic strain, susceptible to methicillin and related antibiotics. Methicillin-resistant Staphylococcus aureus, MRSA, the cunning variant, resistant to methicillin and often other antibiotics, making infections more difficult to treat. Coagulase-negative staphylococci, cons lesser known but significant in specific contexts, particularly in immunocompromised patients or those with indwelling medical devices. Virulence factors, the weapons of war. Protein A, this deceptive molecule binds to the Fc region of antibodies, effectively cloaking the bacteria from the host's immune defenses. Exfoliative toxins, ETA and ETB agents that cause skin peeling and blistering, leading to conditions like staphylococcal scalded skin syndrome, SSSS, hemolysins and PVL. Pantin-valentine leukocidin enzymes that destroy red and white blood cells, contributing to tissue necrosis and severe infections. Biofilm formation, particularly in MRSA strains, creating a protective layer that shields bacteria from antibiotics and the immune system, leading to chronic and recurrent infections. Clinical manifestations, the diverse phases of pyoderma. Imagine encountering a patient whose skin tells a story of battle and healing. Staphylococcal pyoderma presents itself in various forms, each with its own unique signature. Impetigo, the classic tale, non-bullous impetigo. Visualize honey-colored crusts delicately adorning the face, especially around the nose and mouth. Predominantly seen in children, this form is both contagious and characteristic of staphylococcal infection. Bullous impetigo, picture flaccid bulli that easily rupture, leaving behind large, painful erosions. These blisters are a direct consequence of exfoliative toxins disrupting the skin's integrity. Folliculitis, the story of the hair follicle. Appearance, inflamed hair follicles with pustule formation, often on the scalp, face, and trunk. Progression, if left unchecked, folliculitis can escalate into furuncles or carbuncles, transforming a simple story into a more complex narrative of deeper tissue involvement. Furuncles and carbuncles, the deepening plot. Furuncle, boil a solitary, painful nodule with central necrosis and pus, akin to a localized storm brewing beneath the skin. Carbuncle, a cluster of interconnected furuncles, creating a more extensive area of inflammation and sometimes accompanied by systemic symptoms like fever, indicating a more severe storyline. Ecthyma, the ulcerative chapter. Appearance, ulcerative lesions with a crusted surface. Delving deeper into the skin compared to impetigo, often found on the lower extremities. Staphylococcal scalded skin syndrome, SSS the climactic conflict. Appearance, widespread erythema, blistering, and skin exfoliation, primarily affecting neonates and young children. Cause, exfoliative toxins lead to extensive skin damage, representing the zenith of staphylococcal virulence. Diagnostic pathways, navigating the clues. In our quest to identify the true nature of Staphylococcal Pyoderma, we become detectives, piecing together clues from history, physical examination, and laboratory findings. Clinical diagnosis, the art of observation. History, acute onset of symptoms, presence of purulent lesions, recent skin trauma, or underlying skin conditions. Physical examination, identification of characteristic lesions, their distribution, and the presence of systemic symptoms like fever. Laboratory diagnosis, the science behind the scenes. Microscopy and culture, swab collection. Obtain a swab from the base of the lesion before applying any topical agents to ensure accuracy. Gram stain, reveals gram-positive cocci in clusters, a hallmark of staphylococcal infection. Culture, confirms the presence of Staphylococcus aureus and differentiates between MSA and MRSA. Antibiotic sensitivity testing, essential for guiding effective antibiotic therapy, especially in areas with high MRSA prevalence. Molecular methods, PCR. Rapid detection of resistance genes, such as MICA and MRSA, providing swift insights for targeted treatment. Blood tests, complete blood count. CBC may show leukocytosis with neutrophilia. Inflammatory markers, elevated ESR and CRP levels in severe or systemic infections. When to pursue laboratory tests, severe infections with systemic symptoms. Recurrent or chronic infections raising suspicion of resistant strains. Unresponsive to initial therapy, indicating potential antibiotic resistance. Immunocompromised patients where atypical presentations are more common. Therapeutic strategies, the healing journey. With diagnosis in hand, we transition to the therapeutic realm, crafting strategies that effectively combat the infection while preserving the patient's quality of life. General principles, the foundation of treatment, antimicrobial selection. Choose agents based on the suspected or confirmed pathogen and local resistance patterns. Topical versus systemic therapy. Decide based on the extent and severity of the infection. Address underlying conditions. Manage conditions like eczema or diabetes that may predispose to infection. Hygiene and environmental control. Implement measures to prevent spread and recurrence. Topical treatments, the first line of defense. Mupirocin ointment, 2%, indication, mild impetigo, localized folliculitis, and small abscesses. Dosage, apply a small amount to the affected area 3 times daily for 5 to 10 days. Mechanism, inhibits bacterial protein synthesis by binding to isoleucyltRNA synthetase. Retapamulin, 1%, indication, an alternative for impetigo. Dosage, apply to the affected area twice daily for 5 days. Mechanism, binds to the 50S ribosomal subunit, inhibiting protein synthesis. Alternative topical agents. Fusidic acid cream, 2%, apply twice daily for 5 to 7 days, more commonly used in Europe and certain other regions. Considerations, resistance. Monitor for mupirocin resistance, especially with prolonged use. Allergies. Ensure patients are not allergic to the topical agents. Application technique. Proper application is crucial to maximize efficacy and minimize resistance development. Systemic treatments, the deep reach. When infections extend beyond localized areas or when topical treatments fall short, systemic antibiotics become imperative. Oral antibiotics, dicloxacillin, dose, 250 to 500 mg orally 4 times daily. Duration, 10 to 14 days. Note: first line for MSSA infections, penicillinase-resistant penicillin, cephalexin. Cephaloridine, dose, 500 mg orally twice daily. Duration, 10 to 14 days. Note: alternative for those with mild penicillin allergies, clindamycin. Dose, 300 to 450 mg orally 3 times daily. Duration, 7 to 10 days. Note: effective against both MSSA and MRSA, useful in penicillin allergic patients. Trimethoprim sulfamethoxazole, TMP-SMZ. Dose: TMP 160 mg per SMX 800 mg orally twice daily. Duration, 7 to 14 days. Note: effective against MRSA, contraindicated in patients with sulfa allergies. Intravenous antibiotics, indication, severe infections, systemic involvement, immunocompromised patients, or when oral therapy is not feasible. Vancomycin dose, 15 to 20 mg/kg for every 8 to 12 hours. Monitoring, therapeutic drug monitoring, trough levels between 10 to 20 g/ml. Note: first line for serious MRSA infections. Linezolid dose, 600 mg for every 12 hours or 600 mg orally every 12 hours. Duration, 10 to 14 days. Note: effective against MRSA. Potential side effects include thrombocytopenia and neuropathy. Ceftaroline, dose, 600 mg for every 12 hours. Duration, 7 to 14 days. Note: 5th generation cephalosporin effective against MRSA. Surgical interventions, incision and drainage ID. For abscesses, furuncles, and carbuncles, especially those larger than 5 cm, incision and drainage ID is a cornerstone of management. Procedure: clean the area with antiseptic. Make a small incision over the fluctuant area. Express and drain purulent material. Pack the cavity with sterile gauze if necessary. Provide appropriate wound care post. Procedure: adjunctive measures, beyond antibiotics. Hygiene measures: maintain cleanliness of affected areas, encourage regular handwashing. Topical agents: continue use of topical antibiotics even if systemic therapy is initiated. Isolation precautions, in contagious cases like impetigo to prevent spread, especially in communal settings like schools. Decolonization, nasal carriers. Use intranasal mupirocin ointment, 2%, twice daily for 5 days. Environmental control, regular laundering of clothing. And bedding. Navigating complications, the dark twists. Like any gripping narrative, Staphylococcal Pyoderma carries the potential for severe complications if left unchecked. Sepsis, a life-threatening response to infection, particularly in immunocompromised individuals or severe cases. Osteomyelitis, infection of the bone, often resulting from contiguous spread. Endocarditis, infection of the heart valves, more common in intravenous drug users. Post-infectious glomerulonephritis, immune complex deposition leading to kidney inflammation. Chronic skin changes, scarring, hyperpigmentation, or hypopigmentation that can have lasting cosmetic and psychological impacts. Abscess formation can lead to deep-seated infections requiring surgical intervention. Preventive measures, the heroic endeavors. Preventing Staphylococcal Pyoderma is akin to fortifying our defenses against recurring battles. Hygiene practices, regular hand washing, maintaining clean skin, and proper wound care are fundamental. Avoid sharing personal items, such as towels, razors, and clothing to minimize transmission. Environmental cleaning, regular laundering of bedding and clothing in hot water. Decolonization in recurrent cases, identify and treat carriers within household contacts. Education. Inform patients and caregivers about signs of infection and preventive measures. Illustrative case study, bringing theory to life. Patient profile, age, 8-year-old child, presentation, multiple painful, erythematous nodules on the back of the neck and upper arms, some with central pustules and abscesses. History, recent history of eczema, attends daycare, and has siblings with similar lesions. Clinical approach, History and examination. The child's eczema indicates a compromised skin barrier. A perfect gateway for staphylococcal invasion. Multiple abscesses suggest a more aggressive staphylococcal infection, possibly MRSA given the presence of similar lesions in siblings. Diagnostic tests. Swab of the pus confirms Staphylococcus aureus. Sensitivity testing reveals MRSA. Guiding antibiotic selection. Treatment plan. Incision and drainage. ID drains accessible abscesses, providing immediate relief and reducing bacterial load. Systemic therapy. Initiate oral clindamycin at 300 mg 3 times daily for 10 days to tackle MRSA. Topical therapy. Apply mupirocin ointment to surrounding areas to eradicate colonization. Hygiene measures. Educate on regular hand washing and avoiding sharing personal items to prevent spread. Outcome. Over the next week, abscesses resolve with significant reduction in erythema and pain. Follow-up confirms clearance of infection with no complications, highlighting the efficacy of a comprehensive treatment approach. Discussion. This case underscores the importance of a multifaceted approach, combining surgical intervention with appropriate antibiotic therapy, addressing underlying skin conditions, and implementing preventive measures to manage and prevent recurrence effectively. Concluding reflections. The path forward. As we conclude our exploration of Staphylococcal Pyoderma, it's evident that this condition, while common, demands a nuanced and informed approach. From recognizing its diverse clinical manifestations to employing targeted diagnostic strategies and implementing effective treatment protocols, our role as dermatologists is both critical and impactful. By embracing a holistic view, considering epidemiological factors, understanding the pathogen's cunning mechanisms, and committing to evidence-based therapeutic interventions, we can navigate the complexities of Staphylococcal Pyoderma with confidence and competence. Let us remain vigilant, proactive, and compassionate, ensuring that our patients not only recover but also thrive, free from the burdens of infection and its complications. Thank you for your attention. If you found this session helpful, please don't forget to give us a thumbs up and subscribe for more insightful content like this. Your support helps us continue to bring you valuable information and updates. Stay tuned and keep learning with us.